A very good evening to all. Welcome to day 5 of Faculty Development Program on Science of Rehabilitation organized by Department of Physical Education or University and Spinex Global. This task of introducing our guest speaker is a great privilege. I am very excited to introduce him to everyone this evening. Dr. Saurabh Mehta. Dr. Saurabh Mehta has been physical therapy professional for over 20 years. He has practiced and taught in physical therapy program in India, Canada, and the USA. He obtained his entry-level bachelor's degree in physiotherapy from India and went on complete research with master degree in rehabilitation sciences from the University of Manitoba and PhD rehabilitation from MC Masters University in Ornito, Canada. Dr. Mehta holds active physical therapy license in the state of West Virginia. He has been working as a faculty member in the Marshall University School of Physical Therapy since August 2013 and also holds an appointment of clinical associate professor in the Department of Orthopedic Surgery, Marshall University School of Medicine from September 2013. He also practices as a physical therapist at St. Mary Medical Center in Huntington, WV. Dr. Mehta is a member of Marshall University Faculty Senate and also serves across multiple committees within the College of Health Professions as well as MUSOPT, including being a chair of Faculty Search Committee within a MUSOPT. Dr. Mehta remains active nationally in our profession with membership in the American Physical Therapy Association and also within the academics of research, orthopedic and upper extremity and head rehabilitation. Especially, he serves as a member of research committee of the Academy of Upper Extreme and Hand Rehabilitation of the APATA. Dr. Mehta has published over 40 peer-reviewed research articles in national and international journals in the area of musculoskeletal health in elderly, rehabilitation after wrist injury, and outcomes after total knee replacement. Dr. Mehta leads the clinical practice guideline development group for rehabilitation of wrist fractures, which is under the auspices of the Academy of Orthopedics, APTA. Dr. Mehta is also part of international group of scientists who are collectively developing core outcome set of elbow injuries. Today, he will be taking session of understanding the meaning of frailty, prevalence of it, common approach to testing and managing it. Now, not taking much time, I would like to invite Dr. Neeraj and Dr. Saurabh to take the charge of the session.
Thank you very much, Dr. Janvi. Thank you very much, Dr. Saurabh, for joining us from there. We are very happy that you are here. And friends, I would like to tell you that if we call a name, international name in the research, then Dr. Saurabh Mehta is a very big name in the field of research in rehabilitation. He is an authority in physiotherapy research work, and he's my wonderful friend also. Dr. Mehta, we are welcoming you and thank you so much for joining us. We wish you all the best, all the viewers, and thanks for joining us. The stage is yours, sir.
Great. So thank you, everyone. Thank you, Dr. Janvi, and thank you, Dr. Neeraj Bansali, for inviting me. I'm very happy to talk to you about the area that I'm really passionate about, which is understanding frailty in older adults. I'm trying to make this presentation and give you some strategies so that at the end of this session, you will be able to go out in your clinic and implement those strategies to understand frailty in older adults and do meaningful treatment interventions for your patients so that they are at less risk of, severe adverse health events. So let me just start by telling you that I don't have any financial disclosure to declare. So these are the objectives of our talk today. I'll talk about what frailty is and how prevalent it is, and what are the common approaches to testing frailty, and what should you be doing in your clinical practice to manage frailty. So let's get started. I wish you can reserve your questions till the end, unless something burning comes up. And if I'm not very clear and you want to jump in and ask a question, feel free to ask Dr. Bansali, and he will make sure that we answer that question. But try and just reserve your questions till the end, so that way you get a whole understanding about the topic, and then you have your questions ready. So this is just a map that the World Health Organization published in 2015. And this is mainly telling you the percentage of older adults, when we say older adults, 60 years and older, in different parts of the world. And as you can see, you know, Japan is the only country, as you can see here, which has more than 30% of older adults. Uh, but most of the developed countries like US, Canada, most of the Europe, Australia have between 10 to 30% of older adults. And in developing countries like our India and other countries, which are in African region, the percentage of older adults is less than 10%. However, it's slowly increasing. Um, the life expectancy in India has risen by about 10 years. It was in late 50s about 20, 30 years ago. Now it's creeping up to 67, 68. And with the medical innovations, I'm sure in the next 5, 10 years, it'll be in the 70s. So why am I telling you about the prevalent, how many older adults are we going to have in India? We'll talk about that in a little bit. Uh, and this is a very, very important graph that I think we should really understand as to the impact it will have. So the red line that you see here are actually the um, number of children, or those who are under the age of 5. And the blue line here is the number of older adults over the age of 65. So as you can see, over the last 50 years or so, the number of older adults have started to rise, and number of kids have fallen sharply. So much so that about 2 or 3 years ago, this trajectory crossed where we have now more older adults than kids. Why is that a big deal? Well, it's a big deal because uh, there are more retiree populations. There is, more uh, people who would need more health care. So that really places a lot of burden on the healthcare if you have more older adults. And in normal times, it's not a problem. Most of our healthcare system can deal with uh, large influx of older adults. But you know what's happening right now with COVID pandemic. No healthcare system is equipped to handle such a huge influx of older adults showing up at the emergency room and intensive care. It doesn't matter. Most developed countries, you have seen how they've had problems managing the COVID, just because the extra burden that you know the older demographic puts on the healthcare system. And this is the last figure before we delve into the frailty area. I'm trying to build a context that in next 10 to 15 years there'll be more older adults. There have been more older adults in last many years compared to 20th century, right? But there is going to be way more older adults in next 10, 15 years, even in countries like India, um, where the medical innovations are increasing the life expectancy. People are living longer with chronic diseases. Diabetes and blood pressure used to kill people 30, 40 years ago. They have a stroke or heart attack and they're gone. Now not so much. The people are living much longer because of the medical innovation. They're living longer, but not necessarily living healthier. They're living with a lot of chronic medical problems. And not everything can be solved by medicine. Not everything can be solved by taking a drug or taking a pill. uh, you have to think about the person as a whole, and that's where we come in as physical therapists. So again, what is this graph telling you? This graph is essentially telling you that In the next 30 years, this was published, I think, 10 years ago, so 2010. So the trajectory or these numbers are 10 years old, but they're still valid because the projections are up to 2050, that in the next 40 years, by 2050, we are going to see 1,000% increase in centennials. Centennials are people who live more than 100 years of age. So we are going to see 1,000% increase in people who are going to live more than 100 years of age. We're going to see 350% increase in people over the age of 85. We're going to see almost 200% increase in those who are classically uh, in Western world defined as older adults, which is over the age of 65. The retirement age here in North America and I think many European countries is 65. I think in India it's 58 or 60, depending on where you work. But um, after that, most folks are considered older adults. So that's why you see the number 65 here, because that's considered retiree population. So any age group you look after 65, 65, more than 85 or more than 100, there's going to be huge increase in older adults. And do you think all the older adults would be running and jogging in the park every morning? No, they are going to live with a lot of physical and physical problems, physical function and disability related issues. And that's where we come in. Like if you think about, um, the risk of heart diseases, diabetes, other chronic problems, physical activity is very important. They go hand in hand. You do not engage in a lot of physical activity, you do not exercise enough, you do not get proper medical advice from physical therapists as to what is safe physical activity, what is good for you to do and what is not good for you to do. So we need to play a big role in making our society physically healthy, um, because if they're not going to be healthy physically and they're not engaging in physical activities, they're going to magnify the risk of cardiac problems and diabetes. I mean, it goes without saying, right? So this is just to tell you that you're going to deal with what we call as, well, you now see the COVID pandemic. You're going to deal with what we call as aging pandemic. That is the word that has been used for many years now in many research articles and scientific community, and that word is aging pandemic. You're going to see a lot of people with older age and a lot of physical and mental health problems, and our goal is to keep them healthy and physically active as much as possible. So that's the whole point of today's talk. uh, what we are doing, current public health response, is not enough. What we are doing right now is not enough. There is what we call as primary care, there is what we call as secondary care, and there is what we call as tertiary care. If somebody injures and breaks the hip and they go to the hospital is a tertiary care. Like that should never have happened. And that's a third level care. I mean, this is not the most accurate explanation. I'm just trying to explain that so that I can make my point that tertiary care is the third level of care. Uh, you would want the first level of care, right? Which is primary care. Primary care is what happens while patients are still at home. Primary care is what we call as preventative care. What can we do to prevent medical problems? What we could do to prevent that hip fracture that might need patient to seek the tertiary care. I hope I'm clear here. So primary care is extremely important, and that's where our role comes in, preventative healthcare. So just a couple of things before we go into this whole topic, that every time an older adult comes to your clinic, maybe for back pain, maybe for neck pain, maybe for knee arthritis, look beyond the reason for referral. I'm sure that they will refer to you for knee pain or back pain. Try to do more global healthcare screening. Try to see if they're at risk for falls. You wouldn't believe there are more research coming now that people with neck pain, elderly, after age of 65, they have impaired proprioception just because there is a big proprioception cluster in the base of the occiput. And if they have neck pain, especially upper cervical pain, it leads to risk for fall. I mean, more and more people are getting interested now in that. So look beyond the reason for referral, screen for global medical problems, which is screen for fall risk, screen for the risk of osteoporosis, see if their vision is okay. I mean, you can do that. You have been physical therapist, you've been trained to do all that thing. So try to look for all that. Try to screen for osteoporosis. At some time, if I have a chance again, I'll come and do another lecture on how to screen for falls and osteoporosis, because that's another whole area. But that's something that you can do. And for screening for osteoporosis, not everybody needs to have a bone scan. There are some other ways where you can, in your physical therapy clinic, screen for osteoporosis and make appropriate referrals. Sometimes you can't manage everything. If you think that person has osteoporosis, that's not your job to manage. I mean, you can manage with some physical activity intervention, which are absolutely essential, but patient might need some pharmacotherapeutic. So you might need to, work with a physician who in a team-based setting, so you both collaborate and just make sure the patient is given the best care possible. Identify the characteristics of frailty, depression, abuse, and geriatric syndrome. When we say geriatric syndrome, I really mean uh, the frailty. So we'll talk about that. And plan for sustainable outcomes and increase in physical activity. And that's what I've been telling you. To prepare the patients for safe physical activities. Uh, so that brings to the topic at our hand. What is frailty? I guess the big question. People might just put it as simply as it is weakness, and they would be wrong if they say that. People might say it's a disability. Again, they would be wrong if they say that. People might say it's just a balance problem and the risk of falling. People who are frail do have weakness. People who are frail have balance problem. But frailty is not balance deficit or disability of fall risk or weakness. Frailty is much worse than that. Um, so I will spare you the history of how the literature has changed over the last 2 decades on frailty. That's just a too long a topic and too long a conversation. But I'll just tell you what is the essence, or what is the current understanding of frailty is. Um, so there is a big international group that is working on defining frailty. And in 2013, they're still working on it. Nobody has been really pinpointed, provided definition of frailty, but there are some things that they agree on. They actually published a paper, and they advised that there are few things that are characteristics of frailty, but we'll try and define more. So they're still working on it, and will probably come up with their exact definition. But they exactly know that frailty is characterized by impaired physical performance, impaired ability to walk, impaired ability to move around, impaired ability to grip. So there is weakness in hands, and walking speed relates to weakness in lower extremities. So there is weakness in hands, weakness in lower extremities. It has to do with the nutritional status. It has to do with what you eat and what you don't. It has to do with mental health and cognition. Now, again, you might look at it and you might say that we cannot intervene in all areas. We can't give advice about mental health. I agree with that. But we need to focus on the first bullet here, which is the most important part of frailty, which is the physical performance deficit. So, most research and clinicians agree that frailty is a state of extreme vulnerability. Uh, it's associated. I'm going to read this bullet first and then just give you a snippet or a very short summary of what this all means. Most researchers agree that it's associated with decreased reserve to deal with or recover from stressors. And when the reserve is low, minor disturbance can lead to major health problems. And it's associated with increased risk of falls, injuries, institutionalization, loss of independence, disability, mortality, and it has a higher cost of managing it. So in case if that was, I mean, a lot of what it is saying is familiar language, I hope. But what it is essentially telling you, that frailty just means poor physiological reserve. So everybody, you, me, every human being has what we call as physiological reserve that keeps us going. So even if one was to get ill, you know, receiving medical care, hospitalized for example, 2 weeks or 3 weeks, we all know that after that you lose weight, you become a little weak, and after 2 or 3 weeks of hospitalization, I shouldn't say you, I mean whoever is hospitalized, if they're hospitalized for 2 or 3 weeks, they get a little weak, and they when they come home, they need some time to recover and feel better, right? We all know that hospitalization can really bring your energy level down. That works for most of us. If we were any of us was to go to hospital, in the long run we will recover even if we get weak for some time. The problem occurs in older adults who have what we call as less physiological reserve. So if they go to the hospital, they drop down below certain level. They did not have reserve capacity. I remember, we all had what we call as reserve tank in our motorbikes, which if the main fuel runs out, our motorbike runs on the reserve fuel. They don't have a reserve fuel. So the motorbike collapses right in the middle of the road. Same thing here. These folks do not have any fuel in the reserve tank. That's exactly what frailty is. And I'm glad I remember that analogy right now because I think that's a perfect analogy that you do not have a reserve fuel in your tank. So you might just collapse. That's what happens in frail individuals. What do we mean by collapse? Either they die because that's it, they just don't have body does not have any vital energy to survive anymore, and all the organs of the body start shutting down. They don't have energy to keep going, and the end outcome is death. Second is the reserve is so low that but it's there. Their system is still running, but they are not going to be safe at home. So they are what we call as what we see here institutionalization. This is not a huge phenomenon in India yet, I believe. Institutionalization is people are put in nursing homes for rest of their life. People are put in the rehab facilities for rest of their life. They can never come back to home anymore now. They just live there because they are so weak and there is no chance of getting better with them. They're so old, there's nothing you can do about them. So that's what happens. And guess what that happens? I mean, it's very expensive to live in a skilled nursing facility for the rest of your life. It costs them $4,000 or $5,000 every month. If you're not well off, if you're not rich, that's not going to be affordable for you. So the point I'm trying to make is the frailty is that very little fuel in your reserve tank, and you just don't have any energy, and any little event, if you even have a malarial fever, you have to go to hospital, you're not coming back home. If you have a little episode of diarrhea, you're going to hospital, you're not coming back home. Forget about the major events like stroke and heart attack. That's not what I'm talking about. Even a minor disturbance, that's what we say here, that even a minor disturbance can lead to a major health problem. So it's important. This is all tertiary care. Remember, I told you this is like when you're sick and now you have to go to hospital. We believe in primary care, and the whole lecture now is about how we should do the primary management of frailty. I'll throw you some data about the prevalence of frailty, how prevalent it is. So there are things that are common. Frailty increases with age, which again is a no-brainer. I mean, we're pretty intuitive. It's higher in women and higher when you have multiple comorbidities. So if a patient has so many medical problems, they're more likely to become frail. And it's higher in women. I don't think there is a biological difference here that women have biological characteristics so that they become more frail. I think it has to do with the lifespan. Women in general live 4 or 5 years younger than men. So I think there are more women you would find frail than men. And frailty prevalence changes based on how you define frailty. We are going to talk mostly about what we call as frailty defined and characterized by phenotype. And we'll talk about phenotype in a little bit. So if you just think about frailty phenotype, 10% of the population is frail, and 44.2% is pre-frail. And this is over the age of 65. So these statistics are people 44% over the age of 65 are frail. I'm not trying to give you a way to make money or expand your business, but essentially what I'm trying to tell you is 45%, almost 45% of your clientele, and if you even count this 10% from this pre-frail, almost 54% of the older people over the age of 65 require physical therapy. And again, I'm not trying to, you know, market or advertise our profession, but this is truth. I mean, this, they need, if not every day coming to your clinic, they need some advice on a monthly basis. um, you know how they just do a little bit of checkup every now and then to make sure that you check them up every now and then to make sure they're okay. But they need that basically. Some data on okay, just and there's some other definition according to that the frailty prevalence might change. I guess I believe you get a little gist of what I'm saying, so I'm going to move on. um, what it is to be a frail elderly. You are at high risk of hospitalization. You have a greater risk of being a bedbound person. Institutionalization, being bedbound, occurs here. You are put in skilled nursing facility. I guess in most places in India, family takes care of them, but it doesn't matter. They're still bedbound. They do not have any quality of life. They're more susceptible to fall, and above all, there is a high risk of mortality. Like I told you, any little diarrhea, you go to hospital, and there is a chance that you might not survive. So, and why should we actually worry about it? Well, first of all, I do believe that PTs are diagnosticians. We are able to diagnose the physical function impairment better than I would say anybody. There's more research now coming out that we are better, or at least as good as orthopedic surgeons, in diagnosing a lot of orthopedic problems. And we are definitely superior to orthopedic residents who are doing residency in orthopedics. We're definitely better than medical students. So there's a lot of research that is there now that we are much better than many medical professionals in diagnosing physical impairment. We're often the first point of contact. People now know that physical therapists are experts of balance problems, or their stroke patients or back pain, neck pain. They might come to you before they go to the physician, so you are their primary healthcare provider. We are expert in human movement and mobility, and we are most qualified to address physical function deficit. So even if an orthopedic surgeon or other physician diagnoses that there is a balance problem or weakness or some risk of frailty, they're not going to be able to do anything about it. They will send them to you anyways. So I think the $1,000,000 question, how do you assess frailty? I'm going to tell you three specific approaches, and these three approaches it's almost like you will finish this session today, and tomorrow morning you'd be able to assess frailty. They're very, very simple. But these three approaches have been proven, and that's what they've been using. One approach is, two approaches have been validated internationally, and the third approach is the result of our research that we have done, and it's in the stage of publication. So let's just talk about those three approaches. The first approach is the frailty phenotype approach. And the frailty phenotype approach has 5 criteria that you have to assess. And I'm going to go through all criteria. You may take a note. I'm happy to share this PowerPoint later on if you want to. But let's just go through what those 5 criteria are. First criteria is you have to calculate the person's body mass index. I'm sorry, I take that back. You have to calculate the weight loss. You ask the patient a simple question. 10 pounds, or I would say 5 kilograms. Have you lost more than 10 pounds in the last 12 months? The answer is yes or no. No, I have not lost more than 10 pounds in the last 12 months, in the last 1 year, or 5 kilograms. Kilogram is what we use there. Or I have lost or have not lost. Yes or no question. Simple. that question, if they don't know, if they say that, I don't know, I didn't weigh myself, take my body weight 1 year ago, and so I don't know if I lost weight or not. I think I've lost some weight, but I can't be very specific. Well, then you can ask this question. And this is not a question. You just take their height and weight and you calculate their body mass index. It's a very simple formula. You can get it off the internet. But you calculate their body weight. And if their body weight is less than 18.5, they're weak. They don't have the reserve. That's the first sign that they don't have reserve. They're very frail and weak. You know, so that's one sign. So this is just uh, the criteria published by Bone and Joint Institute for body weight, BMI. Normal healthy weight is, between BMI of 18.5 and 24.9. And as you see, Dr. Bansali, who is very fit and healthy, I'm sure he falls somewhere there. People like me, I don't know, we fluctuate between overweight and normal weight, I guess. But for now, I'm normal weight. So this is the classification, and underweight is the folks that I was telling you about. The second criteria you ask is so the second criteria you ask is the grip strength. So I don't know why there is a number 3 here. Maybe I messed up in the labeling of it. I guess I did. So sorry about that. This is actually number 2 criteria, and a grip strength. How do you assess grip strength? Well, if you don't use this equipment, I would suggest you use it, and that's a grip dynamometer. I'm sorry, I'm a little outdated in terms of my perception of how physical therapy practice in India is anymore now, because I haven't seen any patient in India in the last 20 years. So maybe you guys use it, but I don't remember I was using it 20 years ago. It's called grip dynamometer, and again, it's a very simple device. If you don't use it, use it. I'm going to show a quick video. So before I show that, let me just tell you a couple of things. There are 2 or 3 tests that I will show you, that you need to do on patients. It's very important for you to know the technique of that test, and you have to use the exact same technique. You cannot have, oh, the video shows that do this test in a particular way, but I'm going to do it in a different way. No, because then the test does not give you accurate results. The test results are not valid. So try and do that in a very regimented or a very specific way, so that you can get more accurate results. So let's just try and see that.
Here we are today with Callie from Ithaca College, occupational therapy student. So she's helping me demonstrate the use of the JMAR 5-rung dynamometer test. So we're going to use this JMAR manual dynamometer, and usually the average setting for an adult is the handle position number 2. There's 5 settings, and we can adjust that based on the handle setting.
Okay, so I'm just going to pause there here a little bit. Here, when you see this dynamometer, it has 5 notches. 1, 2, I don't know if you can see it or not, but there are 5 notches here. And if you have used it, I guess you would know what I'm talking about. You put it on the second notch. So there is 1 notch here, and then there is second notch. There is 3rd, 4th, and 5th, if you just follow my cursor here. So you put it in the second handle. That's the recommended way of doing it.
So the position of the patient, 90 degrees hip, 90 degrees knee, set nice and straight without any armrests. We're going to have them go ahead and squeeze for me with the right hand. Hold 3 to 5 seconds. Relax. Go to the opposite hand for me. Squeeze again for me. Relax. And usually it's 3 to 5 seconds for a squeeze, and then we go about 15 seconds resting between each set. We average 3 of those together for our overall average of grip strength. Mathewitz as the primary indicator for norms from the early 80s. Grip strength has been shown in the last so many years, there's various studies to show a nice indicator of overall health and wellness. So when you're checking grip strength, make sure you have your patient in the right posture and arm unsupported, nice, sustained, slow, sustained grip, and give enough rest to get muscle recruitment for that next squeeze on the dynamometer.
Okay, so a couple of points. The second handle, the arm straight, and the arm is right by the chest wall, elbow at 90 degrees, and squeezing the grip strength for 5 seconds. Like what? And we just say in English here, hold 5 times. So that's actually 5 seconds. And then you give three trials like that, and you take an average on each side, and you give 15 minutes, seconds rest in between. You always check, for the sake of frailty, you check their dominant hand. Their dominant hand, if they can squeeze less than 17 kilograms if they're women, or if less than 29 kilograms if they're men, that's a what you call as a just take a red dot. You just put a red dot or red mark. There is a problem here, So that's problem number one. Problem number two, problem number one was BMI of less than 18.5, if you remember. So that's problem number one. The grip strength is problem number two. And then third thing you check is the walking speed. So again, I'm going to play a video for that. Again, it's a very specific way. Try and follow that to the T, and I think you would do well if you just follow it, just how it is done. So.
This activity involves walking from one place to another. This is our walking course. I want you to walk to the other end of the course at your usual speed, just as if you were walking down the street to go to the store. Let me show you what I want you to do. Put both your feet together behind this line and walk past the cone at the other end of the course before you stop. Okay? Let me do it. 3, 2, 1, go. Okay? Now I want you to try. Remember to walk at your usual speed and keep walking past the cone. When I want you to start, I will say 3, 2, 1, go. Do you have any questions? Okay, ready? 3, 2, 1, go. That's good. Any questions? This time, I'm going to time you as you walk at your usual speed. Are you ready? 3, 2, 1, go. Now I want you to repeat the walk. I want you to walk at your usual pace and go all the way past the cone at the end of the course.
Okay, so I'm going to just move on because this is what she's doing is measuring it a few times. So again, let me just summarize what she was doing. There was a 4-meter path that you saw, the black tapes at both ends. There was 4-meter path. So the patient stands on the one end of 4 meter, and you give one practice trial so that they know what they involve. You don't time the first time. You don't take the timer out and time how much time it takes for this patient to go from point A to point B. You give a practice trial so they know what they're doing. Second time, you start to take your timer out, and you click your timer on the moment you say go. So you say go, and they start walking on the other end, and you stop your timer when the first leg swings through the ending line. You take your time, and you calculate the gait speed. This is the speed of their walking. Important point, you tell them to walk at their normal pace. This is not a running contest. So don't tell them to run. They're just supposed to walk. At the same time, if they're using a walker or cane, let them have it. Don't stop them. Let them use cane. If that's how they walk, that's fine. And just use the equation, meters per second. So 4 meter, how much time it took them. So if it took them 3.5 seconds to go the 4 meter distance, the gait speed is 1.14 meters per second. It's very simple as that, right? What is good? Anything less than 1 is a problem. If you cannot walk 1 meter per second is a problem. If it's less than 0.8, there is research that shows now that it's a very, very high mortality risk. Okay. And if you need 1.22, at least 1.22, to successfully cross the signal light. I think these norms are developed in the US or in other, I guess, Western countries. What they've done is, you have a green light for pedestrian. You walk from one end to the other end of the, of the intersection or road, and you see that the timer, like you only have like 10 seconds to cross the road or 15 seconds. They say that you need at least 1.22 meters per second to cross the road safely. If you cannot walk that fast, by the time that the light turns green by the time the light turns red for the pedestrian, you would be somewhere in the middle. You would not have crossed it, and you might be hit by something. So that's what they say, that is a safe walking speed. So again, if their walking speed is less than 1 meters per second, that's another mark or a problem. Okay, so we have seen three things. One was the BMI, or loss of body weight. Second thing is the grip strength. Third was the gait. Now let's look at the fourth one, which is the low physical activity level. You ask them, do you exercise? Do you go out every week and walk? Just go for a walk, or maybe bicycle. It's not walking. But if walking, I think it's fine. I think most people in India are used to doing more, walking in the park and everything. So you ask them, one way to assess physical activity is actually to use what we call as rapid assessment of physical activity scale. So there is a questionnaire that they fill out. And if you Google this, you will find it. And, it has some activities that people, let me just show it to you. I think it might be easier for you to look at what RAPA is. So I hope you can see this. This is just a scale. It gives you some example. What is light activity, and what is moderate activity, and what is vigorous activity? And then it asks you question. You rarely never do physical activity. I think depending on the patient, you might see, if they're not comfortable with English, you might have to translate this for them. But you just ask this question, and there are yes or no answers. And you calculate how many yeses and how many nos. And based on the score, you can divide them into, if they're sedentary, I don't know if you can see that or not. Let me just blow it up. If they're sedentary or underactive. So if they get a score of 1 or 2, they're sedentary or underactive. And they get that red dot again, that, okay, there is a problem right here. So this is one way. World Health Organization also has another way. I mean, you can use this too and not use that scale that I was showing you. You just ask him a very simple question. How many minutes you walk every day, and you add them up. If it is more than 150, that's good. In a week, I mean, more than 150 in a week, that's good. If it's less than 150, that's a problem. And again, you give them a red dot there, right? Remember I told you. And if they are less than 100, that's a huge problem. If they're less than 100, walking or exercising less than 100 minutes in a week, big problem. So again, grip strength, weight loss, gait speed, the physical activity, and the last is, I think there is a question that I missed here, and I should say that here, and I will, when I send you the PowerPoint, I'll probably fix it. But the question is basically, you ask them one question. Do you think you get tired very easily? Even if you just get up and go to the bathroom and come back, do you get tired? Or if you just get up and go for, get a glass of water, do you get tired? Do you get tired by just, walking for maybe 1 or 2 minutes? If the answer is yes, that's a red dot, right? So again, that question that I just told you, if they get tired, grip strength, gait speed, physical activity, and weight loss. Now you've assessed these 5 things, and you know what is red mark and what is acceptable, what is not acceptable, right? Let's say if they had 1 or 2 unacceptable score on these 5 areas, you classify them, you tell them that you're pre-frail. You're not frail yet, but you're on your way to becoming a frail person, right? And if they have problem over 3 or more areas, they're frail. I mean, I'm not saying that if they're frail for rest of their life. They can actually return back to pre-frail level, or normal level with appropriate, therapies and everything. But and pre-frail, it doesn't mean that they're pre-frail forever. You can intervene and they become non-frail, or they are not frail anymore again with appropriate intervention. So make sure that this is how you classify. That's one way to doing it, right? The second way to doing it is, I mean, the first approach was a little bit exhaustive. You have to do a few things, but I would say it's more accepted approach. Sometimes you want to run through quickly. This is not your main intervention. They came there for the back pain, and now you're making them do grip exercise and certain other things. They may not like it. Who knows, right? So therefore, you might want to do something real quick, and that is Stillberg frailty indicator. That's actually second and third approaches that I'm going to show you are short and very quick, right? um, so it's a Tilburg frailty indicator is again a questionnaire that patient fills out. Uh, it's a scale, and it is used for identifying people who are frail. Again, I mean, as the name suggests, it's the indicator of frailty, as the name suggests. So let me just go back to this website and show you this tool. So it was developed in Netherlands. So their first few questions, like there is a part A here, if you see. You don't have to fill out the part A for the patient. Just go to part B, which is the components of frailty. The part A is more about, are you man or women? How old are you, and how much money you make and everything. I mean, those questions are just for understanding if there are issues with poverty or nutrition and all that. It's probably not meaningful for you, but you can just use this one. And again, you can Google Tilburg frailty indicator and you will find it. Just ask them this question: do you feel physically healthy? Yes or no? Do you think you've lost more than 6 kilograms in last 6 months? Yes or no? I mean, this weight criteria is a little bit different than the earlier mentioning that I did. Do you have difficulty walking? Yes or no? So simple questions, right? And all they're saying is yes or no. Once they score all these questions, you add the score, which is on the last part for the part B. If they answered yes for the question 11, you give them 0, no 1. I mean, the scoring rubric is right here. All you have to do is just see what they answered and add your score up. If their score is more than 5, you put a label that they're frail. So that it's very simple. If their score is more than 5 for part B, they're frail. So that's the second approach. One piece of advice: this scale is in English. Most of the scales, it is recommended that if you want to actually use the scale in a non-English speaking population, like in India, you have to translate the scale into the local language just to make it more understandable for local communication. So for now, you can use this scale, just translate them for, if you want to use it, translate this scale for them. But in the long term, if there are any professors listening to this talk, or this, physical therapy college faculty members listening to this talk, I welcome you to do a research study where you can translate this. You have to do a proper research of translating a scale. You can't just go to a translator and just translate it. There is a systematic process of how you should do a translation from one language to the other. And I'll be happy to collaborate if you want to do that kind of research. I've already published a couple of papers on translating some of the measures into Hindi and Gujarati. So that's one way to do that. And the cutoff score is more than 5. So if they're more than 5, you tell them that they're frail. And let me just simplify these numbers for you. Okay. I think I'm going to talk about in a language of diagnostic accuracy. What I mean by that is, recently, I'm sure you've heard this. Those who follow the COVID news, I'm sure you follow that the RT-PCR test is more accurate, and the antigen test gives you a lot of false negative. False negative is people who actually have problem or COVID. They have COVID, but if you test them, the test is negative. So that's false negative. So uh, Tilburg Frailty Indicator is a test that has very high sensitivity, 93%, pretty high, right? Like that's a very good sensitivity. Um, I wouldn't say very good specificity. I mean, anytime it drops below 85, it's not a good number. And this post-test probability and posterior negative test. Okay, let me simply tell you what this means. So you actually administer Tilburg to a patient. The patient fills out the questionnaire, and the score is, let's say, 7. It's more than 5, so you say, okay, this person is frail. Okay. Uh, how sure you are that person actually has frailty? You're only 72% sure. Okay. Uh, the patient fills out the questionnaire of Tilburg. The score is 4. It's less than 5. So you say patient is not frail. Patient absolutely does not have frailty. How sure you are the patient is not sure? You're 94% sure that patient is not frail, because if the test comes out negative, meaning the score is less than 5, there is only 6% chance that patient actually has a problem. Okay, so 95% you're sure the patient does not have a problem. So it is good. Tilburg is a good test for telling who does not have a problem. It is not good for telling who has a problem. So it is almost like it has a very high sensitivity. So to diagnose frailty, my suggestion is Tilburg is not the best test. If you want to say the patient who does not have a frailty, it's a good test. But your job is to say who has frailty, right? So that brings me to a third test and the final test, which is the 5 repetition sit to stand test. This is, our research has shown, is most reliable test. And I'm going to run a little video, but this and test, we use it across many patient population. It's a very reliable test. It is a quick way to assess function. So let me play that video to you, and then I'll discuss how you should be using this test in your clinical practice. I guess there is no video. They are showing you the captions. No audio, I mean. I think the audio will come in a little later. Okay, so you see what happened. That patient, stood up and sat down 5 times. Every time they stand up, you have to make sure that they're completely standing up. Their knees are completely extended. They're not like partially sitting, standing up. And every time they sit down, their buttocks have to touch the chair, break the momentum before they stand up again. And as you can see, the back is not uh, against the backrest. Uh, I think it's pretty simple test. I mean, the only thing is that the chair is not against a wall. Usually when you do a test, I think that's probably because they wanted to, take a video of this person doing this test, and maybe this is the best angle that they found. But usually chair is against the wall. So every time they sit down and stand up, the chair does, even if it moves, it's against the wall, so it breaks the movement of the chair. Um, and you 5 times sit to stand, and you just count how many times they do it. Like you say go, and then they start, standing up, and after they completed the fifth repetition and sit down, you stop the timer and see how much time it took them. It's a very simple test. So uh, I've given some. I mean, you don't need to see this is what you just saw, but this is just a, a written description of what was happening in the video actually. So what is the score you want? And the 5 repetitions sit to stand for any age group, you definitely want less than 12 seconds. Okay, but specifically for older adults over the age of 60, you want less than 17. If it is more than 17, this one test on its own, you don't have to take those 5 criteria of grip strength and physical activity and weight loss and BMI and gait speed and everything. You don't have to do that. You don't have to do Tilburg. This test alone can give you a very good indication if somebody's frail or not. So let me just run these numbers down by you. If your person's 5 time rep sit to stand score is, let's say, 19 seconds, right? More than 17. So you say the patient is frail. Okay, how sure you are the patient is frail? You're 92% sure that patient is frail. That's a pretty good odds. Let me tell you, some of these tests that you do in your clinical practice, like Hawkins test or the rotator, all the shoulder tests and all these, the knee test of anterior drawers and everything, they're less than 80% sensitive and specific. They're not really, really good tests, right? So considering what we used in other areas, this is a pretty robust test. It's a very, very good test that we're 92% sure that patient is frail. And I'll spare you the horror of the statistics of what 18% means. I think we'll just stick with the message here that you're 92% sure if the score is more than 17 seconds, the patient actually has frailty. So this is TFI, no, sorry, 5 times sit to stand uh, is useful in ruling in or reject or diagnosing that. So bottom line, frailty is common and it affects many older adults, and with many aging population, um, this is becoming a problem that more and more people are getting frail and they're accessing medical health care. You have a big role to play to improve the frailty. Most common approaches were discussed today, but importantly, try and use the sit to stand score of more than 17s to decide somebody's frail or not. Here's what I would recommend. So you use, if an elderly person walks into your clinic tomorrow morning and you decide to do the 5 times sit to stand and the test is positive, their score is, let's say, 20 seconds, and you say, okay, patient is frail. Then if you think that they're frail, I would suggest in that case that if you're going to treat them for frailty, do the gait speed test and do the grip strength test as well, because they're good tests and you can use them to see if your treatments are working or not. So if their gait speed is less than 1 meter per second, I told you that was a problem. So you treat them for a month or 2 months and see if the gait speed is improving, right? Because that will tell you that your interventions are working. Same thing with the grip strength, right? So if you use sit to stand test and if they're frail, try and do the gait speed and other tests too. That's just a good way to check if patient is improving or not. So I think the other question is, how do you manage frailty? I guess you know how to manage a person who has weakness in the legs and arms. So I'm not going to suggest you what you should do. You are pretty expert in that. But you should really understand that frailty, like I told you earlier, it's not just weakness or physical function. Weakness and physical function problem is something you work on, but the patient also has some other needs like nutrition and making sure that they're taking all the medication and all the other comorbid problems like diabetes and blood pressure and everything are well maintained. So you need to work in a team. Okay. What is the team? The team uh, consists of three people. One is you, physical therapist. Second is dietitian, and third is physician. So always work in a team setting. I work here with we have a dietitian program here in the university where I work. So I work with them and a geriatric physician who works in the medical college. So we all work together as a team in this area. So you just have to find your own team. Make a an association, or however you want to name it, just make a collaboration that you're now going to work as a professional team to provide comprehensive care to all your patients. So what do you do in physical therapy? Well, first of all, you have to engage them in physical activity. If they come to your clinic, you probably put them on treadmill, you put them on stationary bike. uh, Start with what they can do. Sometimes they can say, okay, I can only do for 5 minutes. That's fine. That's what they are at, right? And then increase them up to 30 minutes. You might ask me that can they not do it outside? They can walk outside in the park, or they can walk outside in a gym, in a treadmill. They can do the bike there. The answer is no, they can't. Because remember, this is a medical diagnosis. You should not let them exercise on their own, because they are at risk of falling. They're at risk of having more cardiac problems if they overexercise. So you have to monitor their vital signs continuously before, during, and after all these physical therapy interventions. That's why they need treatment in clinic and not in the gymnasium, or out in the park. Okay, so this has to be monitored by PT. So how do you monitor vital signs? I mean, you're PT, so I don't need to tell you how to monitor, but I have some numbers that I think are useful about what you should be looking at. So the second is strengthening exercise with Theraband. I'm going to just tell you 7 simple exercises, and they were published by these authors. And in the reference list at the end of this presentation, we have one of these references there. You can go and check that article if you want to. But this was a big study done out in Spain, and they found that these exercises were really, really helpful in reversing the frailty. So those who were frail became pre-frail or no frail, or those who were pre-frail became no frail. So I mean, it really helped in reversing the frailty, and eliminating the frailty, if you want to call that. 7 simple exercises. I'm sure you have done it in many patients in your clinic. So again, I'm not going to spend a lot of time in telling you how to do those exercises. Just a picture should be self-explanatory. But these are 7 exercises. So I mean, you can integrate your own exercise. I'm not saying you can. All I'm saying is these 7 exercises were part of that research study. So if you want to say that you're doing evidence-based practice, or you're doing what the research has shown to be effective, this is the way to do it, right? So uh, the first thing I told you earlier, physical activity of 20 to 30 minutes on treadmill. Who says that? Well, Health Organization says that we should be doing 30 minutes a day, 5 days a week. So that's your evidence, right? This evidence of strengthening exercises comes from the Theraband exercises. So one exercise is shoulder flexion extension. I mean, you're not really moving in shoulder extension beyond the neutral. It's just bringing the flexion, arm into flexion, and then taking it back to extension. Shoulder abduction and adduction. So that's another exercise. And again, you know how to do it, so I'm not going to spend time on it. Shoulder external rotation with the Theraband, internal rotation with Theraband, uh, hip flexion extension. So if you see, the Theraband is looped around the lower part of the leg, both sides, and the person is doing flexion extension. You can do just how the picture shows, or you might put the patient near uh, a tread or parallel bar if you have in your clinic, or maybe near a window or something they can hold on to if they feel that they're going to fall down by doing this exercise. So have them hold on to something if they want to do this exercise with the arm support, just if it's safer for them. The other is the hamstring curl. So the Theraband is tied in the on the chair here, and they're pulling it away from me, or you can put a weight cuff. That's another effective way. If you just want to make it consistent with the Theraband, you can use the Theraband. So that's as number 6. Number 7 is long arc quads. Have them sit down in a chair and loop the Theraband on the back of the chair, and then have them straighten their knee. It's very simple exercises. So shoulder flexion extension, shoulder external internal rotation, hip flexion extension, hamstring curls, and quads. Those are 7 exercises. Uh, I'm going to go back to the Theraband here. Okay, so this is what I think I should have told you a little earlier. How many times they should do in a week? The physical activity, the walking part, I'm going to take back one more slide again. The physical activity, remember I told you about the treadmill and bicycle and everything? They should be doing 5 times a week, okay? The Theraband exercise, they should be doing 3 times a week. This is not me telling, this is what the researchers did, and that was effective. So you might want to just follow the protocol. And again, you're PT, so you can modify certain things if the patient is not able to do it. That's your prerogative, but most of the time, try and follow this protocol. So start with the yellow Theraband, and again, I don't know, the elasticity level varies between one company to the other. So yellow is the lightest Theraband here in the US, and blue is a little bit difficult. Black and silver are the most difficult. So I mean, you may have a different difficulty level and color that matches with it. So you just pick what you want. And all exercises in standing and with bilateral, except the quads, long arc quads, are done in sitting. As you see, the patient was sitting and working on the quads. So 3 times a week, the resisted exercise, 5 times a week, the aerobic, the treadmill, and the bicycle exercises. Now coming back to the vital sign, what should you be looking at? The resting heart. So you assess the vital signs. You take their blood pressure, you take their heart rate, you just take a simple pulse, or you take their pulse oximeter, you take their respiratory rate, how many breathing cycles every minute. Before they start exercises, the resting heart rate should be less than 100 beats per minute. Before they start exercise, the systolic blood pressure should be less than 150, and diastolic should be less than 100 millimeters of mercury. This oxygen saturation should be more than 97%, unless they have a COPD like emphysema or bronchiectasis, then their oxygen might be a little bit less anyway to start with. But it should be at least in 90, it should be 90s. It shouldn't be less than 90, even if they have emphysema or something. And the respiratory rate should be less than 20 cycles per minute. If there are 30 cycles or more per minute, you see then that they are short of breath, like they're doing this at the baseline. They're not safe to do exercises. So these are the vital signs you check. If they have a problem here, they need medical management. Don't put them on exercises. They might experience a worse cardiac event, and you don't want to take that chance. So just talk to them. Have you taken your blood pressure medication? Or just talk to them. Go and see your physician. Talk to the physician, because you know the physician is now part of your team. Physician and dietetics are a part of your team. So ask them, okay, well, this person is not really doing well with the vital sign. We can't have them exercise. Just take a look at the medication and see if you can do something about it. But this is what you should see before the your therapy session. During about 15 minutes into exercises, you should check their vital signs again. Have them come off the treadmill and check their vital signs. Their heart rate should be within the limits of target heart rate. So there is an equation of target heart rate you can go and find on the internet. But this is just an example that if their age of 70, their target heart rate should be no more than 127 beats per minute. Okay, so I think the formula is that 220 minus age. So 220 minus age is 70. 220 minus 70 years is 150 beats per minute, and then you take 85% of the 150. So 85% of the 150, 127 beats per minute. So that's how you calculate. You can calculate, it varies for every patient, but I'm just telling you that those who are 70 years of age, this is their highest heartbeat. So if you see their heartbeat to be 135, you need to have them sit down for a little bit, give them a little break before you put them back again. Um, the systolic blood pressure should not exceed more than 180 millimeters of mercury, and diastolic should not exceed 120 millimeters of mercury. These are dangerous zones. These are zones defined by uh, American Heart Association as somebody needing to go to emergency room. Okay, so if you see their heart patient, if you see a patient and the blood pressure is more than 180 systolic and more than 120 diastolic, call 108. I think that's what it is in India. The ambulance will come and they have to go to the hospital. This is very dangerous. They can have a hemorrhage very quickly if they have a blood pressure like that. Their oxygen saturation should not drop below 92, so it should stay above 92 in people who do not have COPD, and the respiratory rate should not be more than 40 cycles per second. That's too uncomfortable for them. So you do this for at least 2 or 3 months. Okay, this is what the recommendation is. And follow up with them and try to administer some of these tests and see if they're improving. If their gait speed is improving, if the grip strength is improving, if their 5 times sit to stand is improving, and you may check, you're going to see them for 2 months and then you check again to see if it's improving or not. You're welcome to take some readings in between too. You don't have to wait till 2 months. If you think patient is improving, maybe in like 3 weeks when after you start your treatment, you can check all these things and see if they're improving, right? Uh, the other things, as they start working with the Theraband on the arms and legs, they're going to have some what you call as DOMS, delayed onset muscle soreness. You know how you feel a little sore after you exercise next day. Uh, you can use your own physical therapy judgment and skills to reduce pain. Give them some stretches, give them some modalities for pain control, whatever supportive treatment you need to do for them so that they can continue their exercises. So again, this is a very rudimentary and basic discussion on what frailty is. I mean, we can spend a day on this, but this is very rudimentary. I think this at least gives you something to think about, something that you can go and work in your clinic, and just maybe try to see if your own experiences gives you your own experiences working with frailty, people with frailty. See if you can learn from it. See if you can uh, find out ways that work better in India. Like these suggestions and these guidelines are based on North America and Europe, right? They hold true for most older people. I mean, older people are older people, doesn't matter if it's India or North America or Europe. So they probably should be good everywhere. But there are certain variations. The average height in India is, I think, 5'7" for men and 5'3" or 5'4" for women. The average height in the US for men is like 3 or 4 inches more. So I mean, all these things really affect these numbers. So sometimes things work a little bit differently in India. So just see if you can learn from your own experiences. If you ever want to do research on this, I'm happy to collaborate and we can facilitate that in India as well. So that actually brings to the end of my presentation, and there are questions and there are references for you if you want to follow them up, and I'm happy to take questions. I intended to keep 15 minutes time for question answer, so I think we are right on the dot. It's about let me see, I think it's about 8:15 in India, what it is, right? So I think we'll take questions now.
Friends, you can write down the questions in the chat group. Thank you very much, Dr. Saurabh. It was phenomenal and quite informative based on the researches. And I think it will be a great help for all of us, because in India, we are hardly following all these things. And now I think it's a demand of the time also. So definitely it will be a great help for all of us. Thank you so much. Friends, kindly write down the questions in the chat group. Yes.
So I'm trying to understand that question. Uh, Dr. Neeraj, can you tell me the questions, because I think the chat box is moving very quickly. So I'm okay. It's right here. Okay, yeah, I can see it. I was looking at a different screen. Okay. RA is rheumatoid arthritis. Is that what it is?
It is rheumatoid arthritis. Yes.
You told about exercise like using Theraband or standing exercise is better, but sick patient with RA, how treating them? So meaning, I think I understand what you're asking is, is it safe to give Theraband and have them stand if they have rheumatoid arthritis? Is that the question, I guess?
Yeah, that's the question.
Yeah, I think you have to innovate. I mean, I don't think that you should, there is always a concept that we are now calling what we call as joint protection. So protect the joints that are inflamed and are degenerated. So you cannot load them more than certain capacity. So of course, if they have a rheumatoid arthritis, you may not want to use a Theraband. Just have them, the weight of their limb against gravity might be enough to give them resistance. And see, I mean, RA patient is not RA patient every time. Has a relapse and remission, right? So if they're in a remission phase where the joints are well controlled and less painful, you might want to add like a very gentle resistance. You might ask them, okay, hold a cup of water and lift it up and down. I mean, you don't have to give a Theraband. The problem with Theraband is the more you pull it, the resistance gets worse. That's just based on the stress and strain curve, right? So you might give them a little constant weight, like 1 pound, or just any half a kilogram or 500 grams, something, and have them hold up and down. That you can do, yeah. And have them sit. And standing is because the standing exercises are more challenging, and those Theraband exercises that I was showing you for the arm, they are a little bit more challenging because you're more upright and there is more room for you to move up and more elasticity for you to work through. So therefore, it's a little bit more challenging. Always good to make it more challenging if you think that patient can tolerate it. But of course, if they have other problems, you have to modify and innovate. This is not a cookie cutter thing that you must do it. You have to innovate and modify, adapt to your patient populations.
Friends, we have posted the link in the description box, so you can take the link from there and you can fill the submission form. Yeah. So what precautions are to be taken for cardiac patients?
So cardiac patients, those vital signs that you saw that I gave you, they work for everyone. I mean, if they're very unstable, if their vital signs are unstable, they're not ready yet. And therefore, it's important to work in a team. Just work with a physician. Just create your own circle that the patient has continuity of the care. It's not that now you tell, okay, go and see your physician, and now patient has to deal with his physician, and physician is not talking to you, you're not talking to the physician, and the patient falls through cracks. So just make sure you create your own circle so there is seamless communication. So you just pick up a phone or write a note or do whatever you need to do. Hey, doctor, there is a problem here. If you just want to see him and then send right back to me, that's the most efficient. So I think the short answer is those precautions that I told you, as long as you follow those vital signs, they'll work well. You just watch for those red flags. If the diastolic raises beyond certain thing and the systolic raises, heart rate raises beyond, just follow that and you're fine with that.
Binav is asking that, sir, how can we convert the diagnosis test language from English to Hindi in proper manner?
So there is a 5-step process. So I think you're probably talking about Tilburg Frailty Indicator. There is a 5-step process. It's I think Dr. Neeraj might remember that about 10 years ago, we met in India. When I came to India, I stayed there for 6 weeks. That was actually one of my research projects that I was translating. I don't know if you guys have heard of DASH, disability of arm, shoulder, and hand. Do you use that measure? I don't know if you've
Yes.
heard. So
Yeah.
I translated that into Hindi. So if you go to Dash website, you can see that my name is there and I translated it. This is a very rigorous process. It's a 5-step process. You can't just go to a courthouse and have a translator translate it into a language. It's a much more complex process. If you just translate it using a shortcut, nobody will accept it. So do it in a right way. Put yourself out in the research literature that, hey, this person translated into Hindi. Be that person. But there is a way to do it. If you want to do it, I can help you there because there is a lot of research involved. But I can always, if you want to do it your own, I can give you the article that gives you all the steps that what you should be following.
Swati Bise is asking for gait test. Time may differ according to the height of the patient. For Indians, what should be the approved time?
I think, to be really honest, 3 or 4. I told you, yeah, they're in the average height in India is a little bit less. I don't think that but at the same time, you can take the fact that they take a little more steps in the same number of time. The longer, taller people take less steps. I and my wife, I think Neeraj knows her pretty well. We are 6 inches apart from each other. I think I'm 5, 6.5, and she's 5 feet, right? Every time we go out for a walk, and I see I have walked for 6,000 steps, and she has exactly walked the same number of same distance, and she has 7,000 steps. And like, how come you have more steps than me? But I think it's just because of the height, So it doesn't matter if they're a little bit shorter. I think they will have more steps in the same time. So I think it should not really change a lot. Yeah, I think you should still use the 1 meter per second. People should be able to walk 1 meter per second. That's pretty basic requirement.
Maitri is asking, is there any test or outcome measure to assess fear of falling?
There are two. One is the activity specific balance confidence scale, and the other is false efficacy scale. False efficacy scale also has a longer version and shorter version. Again, that's the problem with most of the scale, that most of them are in English. ABC scale, the activity specific balance confidence scale, has questions like, do you have problem? Do you think you will, how confident you are that you will not fall if you walk in ice? That question is not relevant to India, right? So therefore, these questionnaires, if you want to use it in India, you have to change some questions to make them more relevant to India. And therefore, there is a whole step and science behind it. You can't just take and do the literal translation. So those two scales you can use right now. And I'm telling you, India is a hotbed for research. Nobody is doing anything like all this translation and everything. It's very, very new. I see some folks from South India and there are few from Ahmedabad are doing some of these things now in the last few years. But I would really like to see that going a lot in India. So yeah, those two scales you can use, false efficacy scale and activity specific balance confidence scale.
Sir, I think this question is already answered in previous webinars regarding the wearing mask during the workout. If you want to give some light over that, sir.
Well, again, I'm not an infectious disease specialist, so I can't don't quote me or don't hold what I say is true. I've heard the experts here, and I'll tell you what they've told me. I think it's like any other rule that if you are in a close vicinity of somebody else doing exercises, then you should wear the mask. It's a very simple rule. But if you're the only person working out in your own house, I don't see why you need to wear a mask. You can do without a mask. But if you're going to a gymnasium and if there is a person right beside you, or there is maybe nobody beside you, but there is a chance that people might come like 10 minutes, you're working out, no mask, and 10 minutes later, somebody else comes and then now you're a little uncomfortable. You have to stop the treadmill and go and run and take a mask. So, I mean, in that situation, you have to wear a mask. It reduces your performance a little bit. People may say it doesn't, but I think it does. I have personally felt it. But if you're in a public place, you should wear a mask because you never know who might come into your close contact. But if you're in a home where you're sure that nobody's going to come closer, you should not. Like when we go out for a walk, we never wear a mask because we know that where we live is not very crowded, so we can safely stay away from people and still do what we want to do. But if you're walking in a park, in a crowded park, then I guess you have to.
Sohan is asking, is there a possibility of occurrence of frailty in younger population?
I mean, there might be a short-term frailty. So for example, if you just go by these 5 criteria of weight loss and walking slow and poor grip strength and everything, if you just think somebody broke their leg, they're not going to walk fast. So you can say that they failed the test, or they lost weight, but that doesn't make them frail. They have enough reserve that they can bounce back once they finish the rehabilitation. So I think there might be a short-term slip into the frailty zone just because they injured themselves or something happened to them. I wouldn't start putting labels on them that they're frail, because let them get some opportunity to get rehabilitation, and after that they might just get better. Who knows? I mean, so I wouldn't start putting labels. I mean, these old people that I'm talking to you about have no injury, are walking outside. They don't say that we have a problem. You can't spot a problem. They haven't been hospitalized recently, but if you test them, they're failing the test. So they have no reason to walk slow. They have no reason for a failed grip strength test. They have no reason to feel tired. They have no reason to actually lose weight. If all that is happening without clear medical pathology that could explain those problems, then there is an issue here.
Sir, Alok is asking that if these tests are negative, so there is no need for blood tests?
Blood tests for what?
For this osteoporosis or...
osteoporosis is a different... I mean, I would never suggest you that you should use this to diagnose osteoporosis. This is purely physical function impairment in older people that cannot be explained by their, anything medically happening to them, right? So osteoporosis, cholesterol and everything, this is not to replace those things. Those are important, and that's why you keep your physician on board. Osteoporosis is a different beast. Whatever I talked today, whatever conversation we had, has nothing to do with the balance fall risk. That's a whole different science. There is some relationship, but what we did today has nothing to do with balance of osteoporosis.
Dr. Janvi has one question. At the age of 60, if anyone is taking part in competitive sports, is it good, especially with the history of cardiac infection?
So cardiac infection, I'm assuming that's a short-term problem. So once you recover from infection, there is no residual problem. So as long as they're vital. So there is, I'm sure you had, I was watching, there was another session yesterday, which was about exercise physiology. So now we are getting into the domain of exercise physiology. It is safe for them if their heart health and their lung health supports it, and these vital signs indicators that I showed you, you can use in anyone. It's not only for frail people. It is safe for them if they exercise throughout their life, and age doesn't matter. What they say is age is just a number. You just turned 60, but you were doing same thing 2 years ago that you're doing now, and it's not affecting you, then that's fine. But if you actually are now starting to do exercise, you've never exercised before, you're starting to do exercise, then you have to be a little bit more careful. Then you have to do it in presence of a healthcare professional who knows what he or she is doing and how to handle if there is an adverse event of angina or chest pain or something from exercise.
Sir, Megha is asking that how to modify with hypertensive patients.
So I guess for short answer is if they have, like I said, vital signs of heart, if their heart rate is above 100, and let's go back to that slide one more time. I don't think we can see that slide, but
I will show it.
So if their heart rate is 150 and more systolic and more than 100 diastolic, that's hypertensive at baseline. I mean, hypertension's diagnosis starts at 130 and over. I mean, so they're hypertensive, but as long as they're taking medication, if they're before exercises, their hypertension is in this range, they're safe to do exercises. There's no need to modify. And therefore, we actually check their vital signs even during the exercise, not just before. So you don't need to modify anything. You just have to see that they are in the good range before they start, and during 10-15 minutes into your exercise session without any modification, they are hitting these benchmarks here, and then you're good. You don't have to do any modification. But if you think that the patient is too weak, too frail, then you don't put them on half an hour on treadmill, just maybe 5 minutes, and have them sit down and see what happens, right?
Sir, Dr. Tarpan sir is also watching us, and so many other principals are there. Dr. Tarpan is saying hi to you. He's your friend, sir.
Yeah. Hello to Tarpan.
So Charu is asking that what is the minimum age of a person to test the frailty? Why do we need to compulsorily test for frailty?
I mean, I think here the minimum age is, we call it 65, because before that, so I'll tell your answer in a brief, and then I'll explain why it is like that. So minimum age is 65 here. I guess in India it's 60. Why do we need to compulsorily test for frailty? I mean, you don't need to test for frailty, but the testing of frailty is for screening. That is essentially what is missing as far as I'm concerned. I mean, things might have changed in India in the last 20 years, so I don't know. But that's essentially what the whole healthcare system is missing in India, and that is preventative healthcare. We always focus on, okay, the problem has occurred, how do I deal with the problem? We never focus on how can I actually do the primary prevention so the patient never has a problem and we never have to deal with the problem. So this is a screening. It is not that, okay, everybody is going to have frailty and let's put all of them into exercise. They may not have frailty. It's like here, we go to our medical physicians once every year, even though we don't have any problem, absolutely no problem, we still go to them. They run all the blood tests and everything to make sure that we don't have a problem. That's exactly when they catch something. I was reading on news, and I think I'm sure those who follow knows that Sanjay Dutt is now diagnosed with lung cancer. He went to the hospital for routine check or something, that was kind of, something came up and he went. It was never his intention to check his lungs out, and they checked his lung and they found the lung cancer. That's the preventative medicine, and that's what happens here, right? So this is more for preventative thing and primary prevention. Why 60 years in India? There is enough psychological research and the social research with that just tells that when you retire, something changes. Your physical activity decreases. The pace at which your brain works changes because you're not engaging yourself in day-to-day task of work that you were. So that was keeping your brain sharp. That was keeping your body sharp. Something changes after 65. And in India, something changes after 60. And all of a sudden, you're entering into this risky zone now where all of a sudden your health starts declining. And unless you supplement it by doing something else, you're not going to be able to prevent that, downward trend. So that's exactly why we need to test for frailty. And that's why the age of 60 and 65, just being the retirement age.
Yeah, I would like to add one more thing, sir. Actually, in our ancient science, Ayurveda, this was the concept of well-being. Ayurveda was more focusing on the prevention aspect and the well-being in general as health is concerned, rather than treating it. But somehow we lost that path, and now we are gaining it back from the Western part of the world.
Right.
So, yeah.
Right. Yeah, exactly. I mean, I think Ayurveda is all about primary prevention, and we just hope that people start looking at it. People, I think, have a little taboo or stigma in India that if you go to a doctor, there is something wrong. So people will talk that he or she went to the doctor. So let's guess or let's gossip what's happening to this person, right? It's not the case. You may go to the doctor just for routine checkup. Just have your blood work done every year, make sure nothing is happening, and you're doing what you need to do.
Yeah, things are changing here also, sir. And now people are becoming more aware, and every 6 monthly, yearly, they are visiting to the doctors for general screening and all. So the things are changing. But friends, being a physios, we can open our new avenues for the prevention field in our India also. As the other medical practitioners are doing, we can also do this in our profession. So what causes frailty?
It's aging, it's lack of physical activity. So age of 60 and 65, like I was telling you, it's the perfect storm boiling. It's the perfect place to become frail. Why? As you age, your system starts getting a little bit weaker. When I say system, I'm talking about your whole physiology, or how your organs work. Your lungs start slowing down, your heart starts slowing down, your kidneys start slowing down. So there is a little bit of reduced performance from multiple organs. Now you add a little bit of less physical activity and not doing anything to actually make those organs work, and that really is a perfect storm that starts causing frailty. So it's just it's almost like you fill your gas tank to the full, and you fill your reserve tank to the full when you were born, and when up to the age of 65 you've used a lot of fuel now, right? So unless you start adding a little bit more fuel to it every now and then, you're running on an empty tank at that time. So I mean, that's what it is. You're running out of vital energy in your body.
Friends, regarding the link, I will share it in the chat box also. Just stay tuned. So one more question: why does the problem of
Sciatic pain
occur in many people?
I think I probably defer that question to Dr. Bansali. He's expert in low back pain. I mean, we all know it's there is no one pathology. Sciatic pain is just a syndrome or symptom. It's not a diagnosis. It's just a manifestation of shooting pain down in the lower extremity because of many things that can occur in the spine, resulting from the instability in the spine or disc problems or arthritis or malignancy or cancer in the spine, you name it. There could be many different things. It's hard to pinpoint one reason for that.
Yeah, very true, sir. I will take, I myself will take one session for sciatic problem.
Yeah, I think you should.
Sorry, sir, this is not. For heel pain, what should do an athlete? I don't think this is relevant to your subject.
Yeah, I don't think that, I mean, we probably should take questions that were relevant to the talk.
Yeah, just a minute, sir. Sudhir is asking how to plan nutrition and diet.
I think you shouldn't plan anything. You should form an alliance with the dietitian. It's the mutually beneficial relationship, not for you, but for the patient. Patient gets the right advice from right people. So you should just defer them to dietitian.
Friends, I have shared the feedback link into chat box also. Kindly have a look there. How many pulse rate after sleeping?
Well, the normal is 60 to 100 at rest. So if you're resting, I'm sleeping, I'm assuming it's resting. So if you're between 60 to 100, it's good. Anything less than 60 is bad. It's the sign of heart failure or weak heart in elderly people. You would find heart rate of 50 or 40 or 50 in marathon runners and heavy duty performers. Uh, I think Lance Armstrong, the famous bicyclist, his heart rate is I think 40. So it's just because his heart is so effective in one pump, it can just dispel so much blood to the periphery. So it changes, but normally 60 to 100, I would say.
Sir, your opinion on role of nutraceuticals in frailty?
I'm sorry, I don't know what nutraceutical is.
I think they are asking about the supplements, nutrition supplements, whether they are helpful to this or not.
So and that's exactly when I say you have to be careful in what you prescribe, because you have to understand that old people have systemic and organ related issues. Their organs are weaker, and some of these powders or supplements are very heavy in protein, and they do not have enough ability, and their liver is weak. It cannot actually process all that extra chemical in the body, right? So you have to be careful in blindly prescribing anything. You really have to know what you're prescribing. So I would say that the supplements are broad termed. I mean, your simple vitamin supplement are fine, but if you really want a patient to have a proper nutritional intake, you should never engage in that. You're not an expert in that.
Can loss of bone density also be a cause of frailty?
I don't think so. So in science, there are two different things: is association and causation. You have to start separating these two out. You can see frailty in people who have poor bone health and vice versa. But does this cause that? No. So that is causation, right? Obesity causes arthritis. That is causation. They're not associated. Do people have high blood pressure if they have diabetes? Yes, it's an association. It's not causation. It's not one causes the other. So when we say causes frailty, that's different than are they associated. Yes, you might see a patient then where they have both problems, but it's not one causing the other.
Are diabetic individuals more prone?
Yeah, there again, it's not a causation, but there is association. But people who are diabetics might be more susceptible to frailty. If you remember one of the slides, I mentioned that frail people have this typical characteristics that they have multiple comorbid conditions. They have heart problem, diabetes, they just feel weak, their body doesn't feel right, and they don't exercise. So one thing leads to another, that they don't want to exercise because their body doesn't feel prepared. And that really puts their physical activity down. So diabetes, the high blood pressure, heart problem may not directly cause it, but it just makes the body weak, so that patient really starts declining in general.
So what is the difference between the stress test and the treadmill test?
I honestly don't know. I mean, if there is a different treadmill test, I think stress tests are done on treadmill. I have recommended Dr. Bansali name of my very good friend who is a cardiopulmonary specialist with the American Board of Physical Therapy Association. He's as close as I have seen any physician any PT being a physician. I think he just operates like a physician. So he will actually be able to tell you the best answer on this.
Yeah, friends, we are lining up his webinar also. Dr. Sujoy, he's a wonderful cardiovascular physiotherapist, and he's a key person in COVID management as far as US is concerned, and Dr. Saurabh's very close friend. So we are going to organize his webinar and masterclass as well. We will declare once it is finalized. Thank you, sir. So there are so many comments are there regarding the way you are answering and the way you have taught. They are so happy because of your knowledge sharing and the way you are explaining everything.
Glad to help. Glad to help. It is hand dynamometer, yeah. It is a JMR dynamometer. Dr. Mansali, I'm not like 20 again. I mean, for the sake of how things are in India, consider me 80 years old. I don't know what's going on. Like, I have been out of touch. So, I mean, if I don't want to assume and stereotype things that are happening in India, but from my memory, I don't think people were using dynamometer at that time.
Now the things are changing. There are few clinics who are using, including us. So now the things are changing here also. Mainly because of the competitive environment and more challenging things. So everyone is trying to be more advanced and more active as far as management and diagnosis are concerned.
I'll tell you one thing about grip strength test that while we are here, just search Journal of Geriatric Physical Therapy or Journal of American Society of Geriatrics and all that. You will see now that just one test of grip strength can tell a lot about the patient, can tell how healthy they are. And there's some benchmark. If their grip strength is that much, they have this problem, they have this problem. So there's so much research on grip strength that grip strength is not about how strong your grip is. And in old days, we used to go to those village fairs where there used to be those big competition where we pull things, and you win a reward or something. But it's a very different now. So grip strength is a very useful test. If you don't have a dynamometer, I strongly suggest you purchase one for your clinic.
I think we should have one separate webinar for all these tests and how with precision we should measure all this, because having equipment is another thing, and to know how to use it and what are the parameters to be taken care of is an entirely different science, and that's what is lacking, I think.
Right. There is a whole science on what we call as psychometric properties, reliability, validity. How do you use these outcome measure? They have to be used in a very specific way, and the score has to be interpreted against many benchmarks. So there is benchmarks for all the balance tests. There is benchmark for grip strength test. There is benchmark for, walking test or the cardiac function test. And if you use that in test and use those guidelines, you're doing what we call as evidence-based practice. Without that, you're just for the sake of it, you're using an equipment. It's like you bought a Rolls Royce, but you just don't know how to drive it. So, you need to learn that lesson too.
So what kind of medical illnesses will worsen the frailty?
Everything. Like I would say more chronic conditions. So if I have to separate what medical illness is, the acute conditions don't, like falling and breaking something. If you're not frail, for example, even if you're 60, 65, you're not frail. If you fall and break your arm or leg or something, I don't think you're going to get really, really frail if you've been very active person. But it's the chronic condition that stay with you forever, like diabetes, heart problems, blood pressure, kidney, chronic kidney disease or liver dysfunction. All these problems actually will worsen the frailty.
Viewers are also eager to have the sessions on this. So there are comments regarding it's a wonderful idea to have a webinar on all the tests. Please let us know, sir.
Yeah, we'll definitely do that. We will definitely. I mean, the plan was to actually do another session on knee replacement. I think I and Dr. Neeraj talked about it. But unfortunately, our school is starting next week, and our labs, like with the COVID, we can only have 10 students in a class. So essentially, I'll be working instead of 3 hours in lab session, I'll be working for 9 hours because it's a small group. So it's just a little unpredictable and crazy. And to do a good quality session, I just wanted to have some time. So we can do it in a time where I feel a little comfortable that I've been able to put up a good presentation and talk to you.
Sir, Navjot sir is there. Dr. Navjot sir is HOD and principal at Parul University, and he is going to have his session tomorrow with us on the hand rehabilitation. The entire session is based on that. Sir, yeah, sir, you have also done lots of research over the hand rehabilitation for years together. I know that. So Navjot sir is telling that he is going to explain a lot on the dynamometer also. So viewers, please stay tuned for tomorrow's wonderful lecture also. It is going to be very, very informative. And Dr. Saurabh sir, we are eagerly waiting for your next session on the knee rehabilitation as well as on the other topics also. Your knowledge will definitely uplift the professional values of this Asian side. Most of our viewers are from India, Bangladesh, Pakistan, and Dubai and Gulf countries and all. So that will definitely enhance the way we all are practicing. So, sir, we are eagerly waiting. Whenever you are comfortable, please let us know. We will definitely arrange those. It will be a pleasure.
Absolutely, no problem. No problem.
Sir, last two questions we'll take, and then we'll wind up the session. Sir, can you brief out some basic ways or tests to diagnose frailty in Indian population?
Okay, so as you know, I discussed 3 approaches. One was that 5-step approach. You check the physical activity level, their weight loss, are they feeling tired all the time, gait speed and grip strength, right? That's one approach. The second was Tilburg Frailty Indicator, and third was the chair stand test, the one what you see on the screen right now. Here is the short answer. You can use these tests right now in Indian population. However, these approaches to test frailty, whether they're really picking up people who are frail or not, like I'm just equating it to COVID test because I think your people are reading on that. Is the RT-PCR test picking up everybody who has COVID, or the antigen test is picking up everybody with COVID or not? Now, those tests are a little bit easier. They're objective, like cholesterol level, blood work, cholesterol level is same, blood is same in India and here. But some physical function characteristics are different in India and US, right? In North America. So the approaches that I told you are validated, developed, and implemented in the United States. There might be some variation in India. The correct answer is to do some research in India. If you want to do it, we can do some research. We can really develop our own guidelines for that. Till those guidelines are developed that are tested and validated in Indian population or a population of subcontinent like Pakistan, Bangladesh, India, Sri Lanka, and all that, these are the only approaches that you should be using because there is nothing out there. Till the new science comes up, you have to use whatever science is available.
True. Does frailty will enable us to find out priorly about the nervous system diseases like Parkinson's or Brown Squat syndrome?
I don't think so. I mean, I think the question here is, can this frailty predict people who are going to have neurological, those are degenerative neurological disorders. I don't think the frailty can pick them up. There's other set of symptoms. I was talking to a researcher, and again, I think this is completely off the topic. I was talking to a researcher, and this researcher was talking about his area was Parkinson's, early signs of Parkinson's and gait in Parkinson, everything. And he was telling me that they are now able to say in the early 30s who are going to get Parkinson when they turn 60. How? Somehow their arm swing is a little bit different. So they have studied Now, people are getting diagnosed with Parkinson in age of 60. How can you get a video of a person when he or she was 30 when you can clearly see the arm swing, right? I mean, it's not even possible. So what they did was they actually identified the celebrities, the actors, politicians and sports athletes and everything, and whoever got Parkinson, because those videos are easily available. They are popular people. Videos are there when they were 30. And one thing they found consistently is that one of the arm swing was not enough. So, you would have symmetrical arm swing on both sides, but one arm swing, they shouldn't be holding anything in the hand. If they're holding something, the arm swing might be different. But I'm talking about nothing in the hand, and they're swinging their arms, and it's very obviously asymmetrical. One arm is not moving at all or moving less, and there was a huge correlation on those people getting Parkinson's. So again, this is a little off the topic, but if you see someone, then I mean, I'm not. It's again, it's not a really right thing to say you're going to get Parkinson 30 years later. But I mean, this is just one association that thought came to my mind based on what my conversation has been. So I thought I'd put it down for you.
It's very valuable information, sir. Thank you so much. Thank you, viewers, for joining us. It was a wonderful session, and we thoroughly enjoyed the way you were participated into the entire process of the learning. And thank you, Saurabh sir, for being with us. And it was very, very informative and very convincing session. We are eagerly waiting for your forthcoming confirmation and sessions as well. So thank you for that. I would like Dr. Janvi to come. Hi, Dr. Janvi.
Hello.
Hello.
Thank you, Dr. Saurabh.
My pleasure.
I would like to take fine. I would like to take this opportunity to thank you on behalf of the Department of Physical Education or University and Spinex Global. I must mention that you are extremely knowledgeable in this field, and you have linked this knowledge with great presenting style. I offer my thanks for taking the time to talk to us. I hope to see you back with us in future events and webinars also. Thank you once again, Dr. Saurabh, for a very informative session. Many thanks to Dr. Neeraj to organize this wonderful session. I think any event success depends on the quality of the speaker. And I must say that the selection of faculty for this FDP has done excellently by Dr. Neeraj. Thank you, sir, for your support and guidance. And big thanks for all the participants for the support and faith on us. So thank you very much, entire FDP speakers and participants to be with us from last 5 days and more days to come. And we look forward to see you tomorrow by 7 p.m. Dr. Navjot will be with us to share his knowledge and expertise on, I think, hand rehabilitation, right, Dr. Neeraj?
Yes.
Thank you so much, Saurabh, once again for very informative and very nice session. Dr. Neeraj, over to you.
Yeah, thank you very much, Oro University, for giving us opportunity as a Spinex Global and trusting on our abilities. Thank you so much for that. Thank you, Dr. Saurabh. Once again, we are very happy, and the way you have taught, and this video is going to be viral in short time only, because there are lots of new informations and valuable informations for all of us. So thank you so much for sharing that with us. Your time is very valuable. Thank you so much, and thank you, viewers. We are expecting you tomorrow at 7 p.m. Thank you, everyone. Thank you so much.
My pleasure. Take care. Bye.
Thank you. Bye.
Welcome.